in the respiratory care program, and I'll be discussing several different types of shock. The word shock is used differently by the medical community and the general public. The connotation between the public is an intense emotional reaction to a stressful situation or bad news. The medical definition of shock is much different. Medically, shock is defined as a condition where the tissues in the body don't receive enough oxygen and nutrients to allow the cells to function. This ultimately leads to cellular death, progression to organ failure, and finally, if untreated, whole body failure and death. Today, we will briefly cover 4 different kinds of shock. They are cardiogenic, obstructive, distributive, and septic shock. Each type of shock affects the body in different ways, but ultimately all lead to multi-system organ failure if untreated. All are very aggressive and need immediate treatment. Cardiogenic shock is a physiological state in which inadequate tissue perfusion results from cardiac dysfunction, most often systolic. Cardiogenic shock is a major and frequently fatal complication of a variety of acute and chronic disorders. Cardiogenic shock often occurs after an acute myocardial infarction or MI. Cardiogenic shock is the leading cause of death in acute MI with mortality rates up to 70 to 90% in the absence of aggressive, highly experienced technical care. All patients with cardiogenic shock require close hemodynamic monitoring, volume support to ensure adequate, sufficient preload, and ventilatory support. The diagnosis of cardiogenic shock can sometimes be made at the bedside by observing the following. Hypotension. The patient will show signs of inadequate tissue perfusion. The skin is usually ashen or cyanotic. The peripheral pulse are rapid and faint. Jugular vein distension and crackles in the lungs are usually present. Peripheral edema may also be present. Heart sounds are usually distant. The pulse pressure may be low, and patients are usually tachycardic. Patients show signs of hypoperfusion, such as altered mental status and decreased urinary output. Ultimately, patients develop systemic hypotension. The blood pressure will fall below 90 torr, or a decrease in the mean blood pressure by 30 torr. Further diagnosis includes EKGs. They should be performed immediately to help determine if cardiogenic shock has in fact been caused by an acute myocardial infarction. An echocardiogram should also be performed as soon as possible to help determine the cause of the cardiogenic shock. Swan-Ganz catheterization is useful in helping exclude other causes of shock. For an example, hypovolemia. The hemodynamic measurements of cardiogenic shock are a pulmonary capillary wedge pressure greater than 15 torr and a cardiac index less than 2.2. On the hemodynamic loop, you'll be able to see cardiogenic shock very easily. All of your pressures will drop. With a myocardial infarction, usually is the left ventricle that is most effective, which is the main pumping mechanism of the heart for adequate perfusion and blood flow. So all of your pressures will decrease, and your pulmonary capillary wedge pressure will be increased. The normal is 8 to 12 torr. The management of cardiogenic shock is an emergency and requires the following. Fluid resuscitation to correct the hypotension. It will also prompt initiation of pharmacological therapy to maintain blood pressure and cardiac output, which I will further discuss. Admission to an intensive care unit setting, and early and definitive restoration of coronary blood flow. Correction of electrolyte and acid-base abnormalities, a placement of a central line, arterial line, and an intra-aortic balloon pump. Pharmacological therapy for patients with myocardial infarctions or an acute coronary syndrome are given aspirin and heparin. Inotropic and or vasopressor drug therapy may be necessary in patients with inadequate tissue perfusion and adequate intravascular volume, so as to maintain a mean arterial pressure of 60 to 65 torr. Diuretics are also used to decrease plasma volume and peripheral edema. Dopamine is chosen to improve cardiac contractility. Norepinephrine, can increase blood pressure successfully in patients who remain hypotensive after administration of dopamine. Epinephrine can also be given to increase the mean arterial pressure by increasing the cardiac index and stroke volume. Oxygenation and airway protection are critical. Intubation and mechanical ventilation are commonly required in patients with cardiogenic shock. However, although positive pressure ventilation may improve oxygenation, it may also compromise the venous return, preload, and other blood pressures to the heart. PEEP must be monitored closely in order to not compromise cardiac output and cause further hypotension to the patient. Arterial blood gases are needed to be managed to provide adequate ventilation and oxygenation while maintaining minimal amounts of PEEP and high pressures. The overall in-hospital mortality rate for patients with cardiogenic shock is 57%. For persons older than 75 years of age, the mortality rate is 64%. Those younger than 75, it is 39.5%. Mortality rates are similar for patients with cardiogenic shock secondary to STEMI. Obstructive shock is caused by the obstruction of blood flow to the body tissues. Obstructive shock results in bodily collapse or near collapse caused by inadequate oxygen delivery to the cells. It is characterized by reduced cardiac output, rapid heartbeat, and circulatory insufficiency and pallor. Common causes of obstructive shock include cardiac tamponade, narrowing of the aortic artery, a tension pneumothorax, and massive pulmonary thromboembolism. Other obstructive rare causes are aortic stenosis, valvular stenosis, cardiac tumor, and pulmonary hypertension. Obstructive shock is commonly classified as a type of cardiogenic shock. With that being said, obstructive and cardiogenic shock present many of the same clinical manifestations. Patients suffering from obstructive shock will often present with the following clinical manifestations. Their skin pallor will be cyanosis around the mouth and the nose. They will have a rapid, weak pulse with cardiac dysrhythmias that are usually frequent PVCs or atrial fibrillation. They'll have a rapid, shallow breathing, unconsciousness, weakness, confusion, anxiety, restlessness, an altered mental status, hypothermia, thirst, dry mouth, fatigue, and distended neck veins. Now I'll discuss in further detail the main causes of obstructive shock. Cardiac tamponade is when blood in the pericardial sac prevents venous return to and contraction of the heart. This is related to trauma, pericarditis, an MI, Beck's triad, hypotension, muffled heart sounds, large heart chest x-ray, and an echocardiogram. Tension pneumothorax. The air is trapped in the pleural space with a one-way valve and air pressure builds up. Tracheal or mediastinal shift towards the unaffected side is a clinical assessment of this. Impending venous return, chest pain, shortness of breath, and decreased breath sounds are also clinical findings. The treatment for this is a needle decompression and chest tube. The pulmonary embolism will present as varicose triad, hypercoagulable, venous injury, venostasis, and the signs will be tachypnea, tachycardia, and hypoxia. Diagnosis for these will be low-risk patients with a D-dimer, high risk with CT chest or a VQ scan. Treatment is heparin and consider thrombolytics. Aortic stenosis. This is resistant to systolic ejection, which causes causes decrease in cardiac function. The patient will present with chest pain, systolic ejection murmur, and diagnosed with an echo. The treatment for this is valve surgery. Mechanical ventilation for obstructive shock follows the same basic principles as cardiogenic shock. The patient needs to be ventilated and oxygenated while maintaining the least amount of optimal PEEP possible. PEEP levels need to be monitored closely in order to prevent compression of the heart and further decline in cardiac output. ABGs should be taken, and the patient's minute ventilation and oxygenation parameters should be adjusted to keep the patient at the appropriate baseline for that in particular patient. If the lungs begin to develop ALI or ARDS, protective lung strategy protocols should be instituted. And that would be, the protective lung strategy is permissive hypercapnia, and the patient's tidal volume will be set at 5 to 8 milliliters per kilogram of ideal body weight. The hemodynamics for obstructive are much like cardiogenic, except if a PE is thrown, your pulmonary artery pressures will increase along with the normal pulmonary capillary wedge pressure. All other pressures will drop and will lead to decreased oxygenation of the body, also to the systemic capillary bed and pulmonary capillary bed. And if treatment is not immediately carried out, there could be death or multi-organ failure